Hello, my name is Dr. Geoffrey Colby, and I am an open cerebrovascular and endovascular neurosurgeon practicing at UCLA. And thank you for joining us today. Today we're going to be talking about brain aneurysms and the basics of brain aneurysms, meaning why we care about them, how we diagnose them, and the risks of these aneurysms. We'll be going over several slides, and thank you for tuning in with us today. If you have questions, feel free to contact us on the web, either using the Twitter hashtag at UCLAMDChat, or you can comment on Facebook below. So let's start off talking about what is an aneurysm. How do we define an aneurysm? As shown on this slide, an aneurysm is an abnormally localized bulge or a widening of a blood vessel caused by a weakness in the blood vessel wall. And they come in all different shapes and sizes, and we'll be talking about that a little bit later during this talk. But you can see here this focal, it's almost like a balloon or an outpouching of the blood vessel. Now if we look at the structure of a blood vessels are actually comprised of multiple layers, almost like layers of a cake. There's the inner layers, or the endothelial cells, that are in contact with the blood that flows through the vessel. There's the middle layers, which is comprised of elastic tissue as well as smooth muscle. And then there's the outer layers. The middle layers comprise the tunica media. And most aneurysms result as a defect or a problem with that tunica media, and therefore a weakness in the vessel wall that expands over time or potentially breaks. Now there are various shapes of aneurysms, and there's various different types of aneurysms as we see here. There's what's called the saccular aneurysm, which has a very distinct sac component to it. We call this the aneurysm dome. There's also something called a fusiform aneurysm, which involves circumferentially the blood vessel wall, so it involves the entire circle of the blood vessel. And then there's something called a dissecting aneurysm, which results from a tear in the blood vessel wall and having blood get into into the tear of the blood vessel wall, and then it expands from there. The most common type of aneurysm are these saccular aneurysms, and that's what we'll be focusing on primarily today. So there are four major blood vessels that bring blood and nourishment to the head and to the brain. There are two carotid arteries that occur in the front of the neck. There's a right carotid artery and a left carotid artery. And there's also two vertebral arteries that course in the bone on the side of the spine that goes up to the head. And these four vessels are very important. They bring all the blood to the head and to the brain, and these are the vessels which many of the aneurysms arise from. Each of these vessels has different branches on them, and these branches go to different structures, either in the neck or in the face, and ultimately into the brain. And the vessels are described based on their relationship to these branches that come off of them, and also through the other anatomical landmarks that the vessels course through, such as when a carotid artery enters the skull or when it enters the coverings of the brain. And oftentimes we will name aneurysms in relation to the vessels that come off of these major arteries and in relation to different structures of the brain. Once these blood vessels get to the brain, the situation becomes very complicated. And there's a whole lot of blood vessels and different branches and different names to these branches. And we will try and keep it simple for the sake of this conversation today. At the base of the brain is something called the circle of Willis. And this is a variety of different blood vessels that literally form almost a circle, and they help communicate different vessels in the anterior or the front of the brain with different vessels in the back of the brain. And this circle of Willis really exists at the skull base. You can see here, this is where it's located on the brain itself, and we're looking at the undersurface of the brain. And there's a variety of different aneurysms that can arise in this location. Aneurysms are very common in branches of the circle of Willis. For example, there's the anterior communicating artery, there's the posterior communicating artery, the top of the basilar or the basilar apex, and these are different common locations for brain aneurysms to arise. But an aneurysm really can arise from any location on an artery. It can be associated with a branch, but it doesn't have to be associated with the branch, and we see them in all different locations. These major blood vessels and arteries course within a different layer of the head, which is not actually inside the brain tissue itself, but rather right on top of the brain. And they course within something called the subarachnoid space. This is a space that's confined by a very thin layer of tissue called the arachnoid membrane, and these little trabecula that almost look like a spider web that form the subarachnoid space. The vessels course within this space as shown here. The other major thing that's in this space is the cerebral spinal fluid, or the fluid that bathes the brain and the spinal cord. And this is very important in the setting of having an aneurysm, particularly having an aneurysm rupture. When an aneurysm ruptures, and here's an example of an aneurysm on a brain artery that's in the subarachnoid space, if this aneurysm breaks, blood spills out of that blood vessel and causes what we refer to as a subarachnoid hemorrhage. And we will talk more about what this means and the dangers of a subarachnoid hemorrhage in a minute. This is a CAT scan of the head, which shows the bright white on the outer surface, that's the bone of the skull. The front of the head, where the eyes would be, is up here, and the back of the head is down below. And this white portion, which almost has the appearance almost like a crab, that's the classic appearance of a subarachnoid hemorrhage. That is blood that's within the subarachnoid space that has spread out because the blood moves with the liquid of the cerebral spinal fluid. And so we see extensive amount of blood in the head here from a ruptured aneurysm. And we also see these darker spaces, which are also fluid spaces of the brain. These are expanded, which is something called hydrocephalus, and that's something that can also result from a ruptured aneurysm. So here's just some statistics about aneurysms and why we care about them. About 1 in 50 to 1 in 100 people in the United States have a brain aneurysm. Most of those people don't know about it because they're generally asymptomatic. About 8 to 10 people per 100,000 suffer from a subarachnoid hemorrhage. And if we take the total population of the United States, this represents about 30,000 people. So there's a lot more people that have brain aneurysms than people that suffer subarachnoid hemorrhages, which is a good thing. However, the true number of ruptured brain aneurysms is likely higher because a portion of the patients that have a ruptured brain aneurysm and a subarachnoid hemorrhage will die before they reach the hospital, unfortunately. A ruptured brain aneurysm is fatal in about 40% of cases, or 40% of patients with this problem. Of the patients that survive this event, about 2/3 of them will have some sort of permanent neurological disability. So, if possible, we do everything we can to avoid a subarachnoid hemorrhage. Now, what are the risk factors of having an aneurysm and having a ruptured aneurysm? There's a variety of different risk factors, and they fall into two main categories. There's what we call modifiable risk factors, or risk factors that we can influence and potentially change. And then there's non-modifiable risk factors, and those are risk factors that we can't change or can't influence. The modifiable risk factors, also called behavioral risk factors, are things like hypertension. If you have high blood pressure, we can treat that with medication. Smoking, if you're a smoker, we could potentially help you to stop smoking. And also things like alcohol abuse and use of certain drugs such as cocaine. Those are all things that can help cause aneurysms and help lead to subarachnoid hemorrhage, but those are things that we can help you with and help reduce the risk of those problems. The non-modifiable risk factors are things like what sex you are. Okay, so female sex is associated with a higher risk of having a brain aneurysm and having a ruptured aneurysm. History of a previous subarachnoid hemorrhage. A family history of a subarachnoid hemorrhage, meaning having a first-degree relative with either aneurysms or having had a subarachnoid hemorrhage. And different genetic syndromes, such as polycystic kidney disease, Ehlers-Danlos, Marfan syndrome, neurofibromatosis, and various other problems. So patients frequently ask about, I have a family member with an aneurysm, or I have a family member with a subarachnoid hemorrhage. At what risk am I because of this association with my family? So about 10% of the time, there's clustering within families of aneurysms and subarachnoid hemorrhage. And there is a higher risk of having, as an individual, if you have a family member with either an aneurysm or a history of subarachnoid hemorrhage, you are at higher risk than the general population. And there's various studies that demonstrate these facts. Here's an example of a study looking at the risk of subarachnoid hemorrhage according to the number of affected relatives with aneurysmal subarachnoid hemorrhage. If you have one relative, one first-degree relative that's had a subarachnoid hemorrhage, you're at about 2 times the risk of the average person for having a subarachnoid hemorrhage. If you have 2 or more relatives with a subarachnoid hemorrhage, you're at 50 times the risk of the average person. Okay? And this is independent of the gender, the age, and the type of kinship, meaning parent, children, and sibling of the relative with the subarachnoid hemorrhage. So in general, if you have family members with subarachnoid hemorrhage or aneurysms, yes, you are at higher risk for having an aneurysm and a subarachnoid hemorrhage. And it's something that if you get counseling for an aneurysm, that your doctor should certainly talk to you about in further detail. So a question that commonly comes up is, why do aneurysms form and why do they rupture? And the real answer is we don't fully understand all of the things that go into this, but there are multiple components that we do know about. Aneurysms form because of a lot of different factors. There's tissue degradation, there's inflammation in the wall of the vessel, there's the hemodynamics, or how the blood flows in that area of the blood vessel. There are genetic components, environmental components, and hormonal components. All of these can lead to the weakness in the wall of the vessel. And once there's a weakness in the wall of the vessel, that weakness can enlarge over time, or it can just thin out the wall of the vessel and the aneurysm can break, and that leads to the rupture event. So there's a lot of features of aneurysms that we consider. It's not just you have an aneurysm or you don't have an aneurysm. There's a lot of features that we're interested in and we care about when making an assessment of a patient with an aneurysm. And here's just some of those features. One of those features is the location, or where is that aneurysm located and which blood vessels are involved. We talk about things such as intradural versus extradural, and what that means is the aneurysm inside the coverings of the brain, or intradural, or is it outside the coverings of the brain, or extradural? That distinction is very important. Aneurysms that are inside the coverings of the brain, if they rupture and break, they cause a brain hemorrhage, and that's a very dangerous situation to be in. Aneurysms outside the covering of the brain, if they break, we're not as worried about a brain hemorrhage, but they can also cause other problems. The other thing is the anterior versus posterior circulation. Aneurysms that come off of the carotid artery or some of its branches in the brain, we typically refer to those as anterior circulation aneurysms. Aneurysms that come off of the vertebral arteries or the basilar artery or its branches, we typically refer to those as posterior circulation aneurysms. And there's been a variety of studies looking at different aneurysms, and it's thought that posterior circulation aneurysms rupture more frequently than anterior circulation aneurysms, although anterior circulation aneurysms can still be problems. This is just an example of a posterior circulation aneurysm that we see here. That's a very large, what we call basilar apex aneurysm. We also care about the shape and the morphology of the aneurysm. When we talk about aneurysms, we talk about the aneurysm dome, or the bulk of the aneurysm, and we also talk about the aneurysm neck, or the opening of the blood vessel that leads into the aneurysm. And we're interested in the sizes and shapes of all of those things. We also want to know whether the aneurysm has a nice smooth round appearance, or does it have extra bumps and other features that we think is associated with more weakness and more problems with the aneurysm. Here's just a variety of different examples of aneurysms as shown by these blue arrows, and you can see not all aneurysms have a very friendly, smooth appearance. They have these other kind of outpouchings and morphological irregularities that we think makes the aneurysm more dangerous. We're also interested in associated branches. So are there branches associated with the aneurysm? There's the vessel the aneurysm comes off of, but are there other branches that we want to preserve coming off the aneurysm neck or nearby? Now, size is also a feature of the aneurysm. We talk about aneurysm size very frequently, and it's thought that aneurysms of certain sizes may be more dangerous than aneurysms of other sizes. And the general consensus is that the bigger the aneurysm in general, the more dangerous it is, but that's not the full story, because size is just one feature. And smaller aneurysms can actually still rupture and cause problems. These are examples of some very large aneurysms that you can see. Here's a big aneurysm here that's multiple times the size of the normal vessel that it's coming off of. Now, these are some intraoperative pictures. So these are pictures of aneurysms that are taken during surgery. And you can see that size is just one feature, and the thickness of the blood vessel wall is actually the most important feature when it comes to an aneurysm. Now, unfortunately, in modern medicine, we don't have the ability to measure the thickness of the aneurysm wall. So we use other features about aneurysms to try and assess whether an aneurysm is dangerous or not. But sometimes when we go to surgery, we see quite a lot of variability in how thick the aneurysm wall appears to be. Here's an example of a 4 millimeter aneurysm. This is what's called an MCA, or middle cerebral artery bifurcation aneurysm. And this is the dome of the aneurysm here. And you can see the dome of the aneurysm here looks pretty similar to the vessels that it's coming off of. So I would say this aneurysm wall is about the same thickness as the normal vessel. But that's not always the case. Here's two other pictures. These are also small aneurysms. One of them is 4.4 millimeters in size and one is 5 millimeters in size. And you can see very different appearance of these aneurysms compared to the first one that I showed you. This aneurysm example has a different color than the blood vessel it comes off of. There's multiple little bumps on this aneurysm here. You can see here, this is actually a whole entire another bump. So this aneurysm has a lot of other features to it that we think is very dangerous. And this is an aneurysm that probably would have ruptured at some point if we didn't get to it in time. Here's another example. This is a 5 millimeter aneurysm seen here. This aneurysm has some yellowish appearance here. Okay, that's some atherosclerosis or some plaque in the wall of the aneurysm. And then it has some other areas which are very bright red in appearance. And these are almost like hot spots. These are areas of inflammation that we think have more weakness and more problems than the other portions of the aneurysm. And these are all very small aneurysms, and there are doctors out in the community that would say, based on size alone, some of these aneurysms don't need to be treated, but we can see when we actually look at the aneurysm that they look quite dangerous and have a very thin wall. Here's a final example. This is a very small aneurysm. This is an aneurysm that's 1.5 millimeters in size. This aneurysm was seen during a surgery to try and address a different aneurysm that was larger in size. But you can see even a very, very small aneurysm, as shown here, has a quite kind of ugly, angry appearance to it. This is a very small aneurysm. It's bright red in appearance, very different in appearance than the normal vessel that it comes off of. This is an example of a blood vessel with a very thin wall, and even though the aneurysm is quite small in size, I would say that this aneurysm is dangerous and very prone to rupturing. So I came to UCLA from Johns Hopkins, and while at Hopkins, with my close colleagues over there, we performed a study looking at the different aneurysms that ruptured in those patients that came into Johns Hopkins over a 25-year time period. And I'm just going to share a little bit of that data with you. So this is a graph that looks at different 5-year time intervals, starting from the early 90s to the present time. So this is early 1990s, late 1990s, early 2000s, late 2000s, and then the last 5 years. And over that time period, the location of the aneurysms in patients that came into that hospital were about the same over time. You can see these different bars. Some are a little higher than others, but overall it's about the same trend when we look at aneurysms in the posterior circulation, the middle cerebral artery, the internal carotid artery, and the anterior cerebral arteries. So the location of aneurysms has stayed about the same over the past 25 years. When we look at the size of the aneurysms coming in over that 25-year time period, there's actually quite a different story. The very top row represents very large aneurysms, or aneurysms greater than 25 millimeters in size. But when we look at aneurysms that are considered small or less than 10 millimeters in size, that percentage has actually increased over time. Back in the early 1990s, a little over 50% of aneurysms coming in ruptured were less than 10 millimeters in size. In the last 5 years, that number is over 80%. So there has been a significant growth in the number of small aneurysms we see coming in ruptured to major academic medical centers. If we look at very small aneurysms, or aneurysms less than 5 millimeters in size, that number has also grown significantly to the point where in the last 5 years, about 50% of the aneurysms coming in broken or ruptured were less than 5 millimeters in size. So this data shows us that small aneurysms can still be dangerous, and size is just one portion of the story when we're addressing an aneurysm. This is just a slide summarizing that data, saying the percentage of very small ruptured aneurysms or aneurysms less than 5 millimeters in size has risen from 29% during the initial 5-year time period to 50% in the most recent period. Likewise, in the past 5 years, aneurysms less than 10 millimeters in size accounted for 84% of aneurysmal subarachnoid hemorrhage. This is an example of a very small aneurysm. This is about 2 to 2.5 millimeters in size, and the example of the subarachnoid hemorrhage that it can cause. So what are the symptoms of an aneurysm? How does a patient know they have an aneurysm if it's not ruptured? So most of the time these aneurysms are actually asymptomatic and the patient doesn't know they have them. Sometimes there are symptoms associated with them. They can cause headaches. They can cause what's called cranial nerve palsies, which when the aneurysm reaches a certain size can push on some of the nerves in the head and that can lead to things like dilated pupils or blurred or double vision. They can cause pain behind the eyes, weakness or numbness, and sometimes even speech difficulties. But as I said, most of the time an unruptured aneurysm is asymptomatic. The most common patient that I see in my clinic with an aneurysm is a patient that has what we call an incidentally discovered aneurysm. It's a patient that presented to either their primary care doctor or a neurologist with, say, a headache or dizziness or some other kind of neurological symptom, and that wound up to getting some brain imaging and an aneurysm was found. But most of the time we don't attribute those symptoms to the aneurysm itself. What about the symptoms of a ruptured aneurysm? If an aneurysm breaks, that's very different. That is incredibly symptomatic, which is very different from an unruptured aneurysm. When an aneurysm breaks, it commonly causes sudden and severe headache. The classic description is the worst headache of your life. Okay? It can also lead to a host of other neurological problems: nausea and vomiting, loss of consciousness, neck stiffness, sudden change in vision, either blurry vision or double vision, dilated pupil or a drooping eyelid, sensitivity to light, sudden pain behind the eye, a sudden change in mental status, dizziness, trouble walking, weakness and or numbness, and it could also cause a seizure. So there's a lot of things that go along with a ruptured aneurysm and a lot of problems that can cause, and it's usually not a subtle event. So how do we diagnose aneurysms? How are aneurysms found? As I mentioned, most of them are found incidentally. Usually the first-line screening tool in a patient that comes in with some sort of neurological complaint is either a CAT scan or an MRI. And to look at the blood vessels, we do something called a CTA, where the A stands for angiography, or an MRA, where again the A stands for angiography. Now these are good screening tools, but they're not perfect. And the number of these studies has drastically increased over time. This is a scientific paper looking at the number of head CTAs and head MRAs that have happened between a 5-year time period from 2002 to 2007. And there's been a huge increase in the number of CTAs, actually an 800% increase in head CTAs during that time, as well as a large increase in head MRAs during that time, 40%, but certainly not as big as the number of CTAs. Now, as I said, these are good screening tools, but these are not perfect studies. Here's a paper that was put out by my colleagues at Johns Hopkins looking at CTAs and how good are CTAs at diagnosing aneurysms. And they found that about 20% of the time, CTAs were wrong, either wrong on the positive side, meaning they saw an aneurysm that didn't exist, or wrong on the negative side, meaning they missed an aneurysm that was really there and found in later studies. And most of the time when these studies are wrong, they're wrong about these smaller aneurysms, aneurysms less than 5 millimeters in size, and really more even aneurysms less than 3 millimeters in size. And as I've shown in my previous slides, even these smaller aneurysms can be dangerous sometimes, so these are things that we don't want to miss. Now, as technology improves, so do the studies, and our ability to pick up smaller aneurysms will increase over time with these non-invasive procedures. MRA, it's the same type of story. So here's again a paper that was put out by my colleagues at Johns Hopkins looking at the accuracy of MRA in detecting aneurysms. And they found, again, a similar situation where, in this case, false MRA positive cases, meaning aneurysms found on an MRA but ruled out by subsequent imaging studies, were as high as 38%. And in an additional 21% of these cases, the MRA may have seen an aneurysm, but either the location of that aneurysm, its association with branches, or the number of aneurysms found was different when further imaging studies were done. So what is the gold standard imaging study for looking at the blood vessels of the brain? The gold standard is something called a catheter cerebral angiogram, and this is performed on a room in a machine that looks something like this. And this is different than a CAT scan or an MRI in the sense that a catheter cerebral angiogram is an actual procedure that we perform, but it's something that we perform very safely, particularly in centers that do a lot of this, such as UCLA. The catheter cerebral angiogram gives us kind of magnificent pictures such as this. This is an example of an injection of a vertebral artery that comes up from the bottom. This is the basilar artery that sits on the brainstem, and here you can see a very large aneurysm of the basilar apex. This type of picture is called digital subtraction angiography, or DSA, and that is the type of image that you get with a catheter cerebral angiogram. And this allows us to see very fine details of aneurysms. Here's an example of a DSA or digital subtraction image which shows a basilar apex aneurysm. These are some of the computer reconstructions that we can do of the blood vessels that show the very fine details of irregularities of the aneurysm dome. You can see all these extra little bumps, and we can really hone in and see the relationship of the aneurysm to the vessels that it comes off of. And this helps in guiding treatment. So really, when we have a patient with an aneurysm, that patient really needs a customized plan. You have to take into consideration the patient details. That would be the patient's risk factors, their other medical comorbidities that they might have. We then take into account the imaging studies that the patient's had and look at the exact details of the aneurysm, its location, its size, its morphology, associated branches. And we have to put all that together and formulate a customized plan for that patient. And it's really not a one-size-fits-all solution. Here at UCLA, where we have expertise in all the different types of treatments of aneurysms, we really try and find the right solution for that particular patient. And it's kind of like going into an ice cream shop and finding the exact flavor that suits you the best. So to summarize what we've talked about today, a couple bullet points. Brain aneurysms are relatively common. Risks of brain aneurysms are both modifiable and non-modifiable, meaning some things we can change and some things we can't. A ruptured brain aneurysm is very dangerous, and that's something that needs to be addressed immediately. The risk of a brain aneurysm rupturing depends on many features of both the aneurysm and the patient, meaning the patient and their specific risk factors, the aneurysm and its specific factors. And really, a patient with a brain aneurysm should be evaluated by a cerebrovascular specialist. And this is a very important point. I'd like to say thank you for joining us today. This is kind of the cast of characters at UCLA that's involved in treatment of brain aneurysms. Here's a picture of myself. Here's my colleague, Anthony Wong, who's an excellent open cerebrovascular neurosurgeon, and then my colleagues in interventional radiology as well as interventional neurology that are also involved in the treatment of brain aneurysms here at UCLA. Here's some links if you'd like to go to the neurosurgery website and the cerebrovascular webpage on the neurovascular site, as well as the neurointerventional radiology site. And again, if you have any questions, please feel free to log in and to ask your questions. And I think we have some questions that we'd like to go over. Okay, so the first question is there a medication that I can take to cure my brain aneurysm? And unfortunately, the answer at this time is no. Okay, as we talked about, an aneurysm is a structural defect in the blood vessel wall. All of the forces in the blood vessel push outwards. Arteries are high-pressure blood vessels, and all of the forces keep pushing outward on the blood vessel wall. And what this means is the aneurysm is constantly under stress. So there's no pill that we can give to actually fix the aneurysm or to shrink it in size. But we can treat, again, those modifiable risk factors, things like hypertension and smoking and other problems associated like that. Okay, so the next question is, what activities should I avoid after being diagnosed with a brain aneurysm? So this is a common question that patients have. They're diagnosed with an aneurysm. Maybe there's a plan to watch it closely over time. And there's very commonly a question of what are the things I can and cannot do. And there's actually not a whole lot of scientific literature talking about what restrictions are necessary to prevent an aneurysm from breaking. We really try and use our common sense from this standpoint. We want to avoid activities that have the blood pressure really high, and if we can maintain a good blood pressure and have your blood pressure treated, that's really the best thing that you can do. But we also don't like to give you too many restrictions that really limit your quality of life. We want you to be able to go out and do the activities that you like to do. So if you are a patient on the outside and you have an aneurysm and you're really being told you can't do any of the activities you like to do, you should probably come to a place like UCLA and get your aneurysm assessed, because we might be able to treat it and get you back to doing all the things that you like. Here's another question. My father died of an aortic aneurysm after successful surgery to repair it. He was a smoker for almost his entire life. I have never been a smoker. Does my father's history increase my risk? So there are certain situations, this kind of gets back to the genetic conditions that cause aneurysms. Some of those genetic conditions that I mentioned such as Marfan's disease and Ehlers-Danlos, they can predispose to aneurysms in different locations of the body. That can also include the aorta and other vessels of the body. And those patients with that sort of family history of a genetic disease should certainly get screened for aneurysms in general. A sporadic event where a patient has an aneurysm of the aorta that's associated with various risk factors of aneurysm, such as smoking, a family member of that sort of patient does not necessarily need to be screened. And in general, most people would recommend that screening is not necessary for that. Okay, well, I would like to thank you for joining us today. I hope that this was an informative session. And once again, if you have problems, questions, or concerns, and you'd like to see one of our specialists, please feel free to reach out. We're always available.